There we go. Now we got a copy.
Okay, are you okay for us to start?
Yep.
Okay, Michelle, sorry about that. You want to get started?
For joining us. As I said earlier, my name is Michelle Robis. I'm the Interim Director for Perioperative Services. We've got the agenda for today's meeting up on the screen today. We're going to start with some ground rules. Kelly's going to take us through that, and then Dr. Kelly is going to follow with a brief introduction and the focus of today's meeting. Sylvia will introduce our guests for today, and then we'll go through the roles of the PPE task force, and then we will have a question period, and then Kathy Craig will take us through the Ministry of Labor visit and report.
Thanks, Michelle. Hi, everybody. It's Kelly Gardner. I'm the clinical manager for PACU and same-day surgery at the Juravinski. As you can see, everybody or a lot of us are new to this format, and some people might be more comfortable than others. So please bear with us if we have a few glitches. And we would like to thank IT for being here with us to assist with some of our challenges this afternoon. As you probably saw, this session is being recorded, so it can be shared with those who may have not been able to attend today. If you are in a room with others, please ensure to continue with social distancing or ensure that you are wearing a mask. Everybody's line will be muted. If you have something that you would like to say, you will need to ensure that you unmute your line. Please also introduce yourself when you are going to speak or ask a question. If you would like to ask a question, you can use the chat feature at the bottom of your screen. There's also, beside the chat feature, a participants button at the bottom. You can use that. If you press on that, you'll see an option to raise your hand if you'd like to ask a question. And we will be watching that chat box and the raise hand feature throughout and try to do our best to answer any questions that might come up. So I think with that, I'll hand over to Dr. Kelly, and he can discuss the focus of today's meeting.
Great. Change the agenda. No, you don't need to see me now. I'll take a break. So thank you, welcome. Thank you everyone for making time to listen to this, be involved in this discussion, and also people who will be watching it a bit later on. Thank you for sort of dialing in. If I basically forgot all the ground rules that Kelly's just given us, so I apologize if I break them. I think really it was just a little introduction today. So really this is about the PPE in the Periop setting in the ORs. And we'll just say the last 12 weeks or so, 10, 12 weeks now since COVID sort of came and sort of into our daily lives. It's been quite phenomenal for the amount of work and change and just the resilience of the team in Periop. And I'd just like to state that, please, that it's been absolutely fantastic. It's not a surprise to me because I work with you all every day and I just know how wonderful you are. But I think we really have done a fantastic job. And certainly corporate-wide, that has been identified of the role that the Periop teams have played, and people are very grateful for that. I think today is about looking at the PPEs, and certainly one of the things that COVID has made us do, and I think we have Dominic and Sarah on the line, and they'll be introduced in a minute. COVID's made us really refocus on some of the infection control standards and things we've had in place, but maybe we'd forgotten a little bit about. And I'll be the first to admit in the last few years, and people who've worked with me will have remembered if the smoke evacuator was getting rid of my pneumoperineum, I would often just gently tell people to maybe just unhook that if they would. And that's certainly something we don't do anymore because of our heightened awareness. So I think that today we're going to talk about some of the sort of changes that have happened, some of the things that we're doing to keep everybody safe, especially now as I think you've all heard this morning, the government changed Directive 2, which allows us now to start to ramp up some of the surgical activity that we've had to close down in the beginning, in the middle of March. So I'm going to pass the computer back to Sylvia, who's going to introduce our guests, and then we'll go from there.
So, hi, everybody. I mean, everybody knows me. I have the pleasure of introducing our team that's here today, and thanking everybody to taking the time. So I don't know if you want to wave as we mention your name so people can put a face to the name, but we have Dr. Dominic Mertz with us today, and he is the Medical Director of Infection Prevention and Control. Dominic, I don't know if you're on screen. Do you want to give us a wave?
I already waved while you were.
Oh, there you are. Hi, Dominic. We also have Dr. Sarah Kahn, infectious diseases specialist and infection prevention and control. Dr. Kahn, a little wave. Hi. Oh, you're muted there. Sorry. We can't hear you. You're muted.
Sorry, I do tend to keep my video off just to prevent the cutting up, so I'll exit, but happy to meet everyone today.
Very nice. We have in the boardroom on E111, we have Dr. Susan O'Leary, who's everybody, we all know her, our HHS Chief of Anesthesia. We have Dr. Stephen Kelly, our Surgeon-in-Chief with us. We also have, she's at the end of the room here with us, and she'll have some screen time in a little bit, but we have Kathy Craig. Kathy is the Juravinsky Safety Specialist from the Health, Safety, and Wellness Department. And we also have Jeff Mullaney. He's our Senior Safety Specialist with Health and Safety and Wellness. Jeff, you want to give us a wave so we can put a face to the name? I saw him earlier. All right. He was.
I am here. I don't know if you can see me.
Okay, I can see you now, so that's great. Thank you, everybody, for taking time out of your day to kind of be here with us today. So now that I've kind of introduced who our team is today on the call, I'm going to turn it over to Dr. Mertz and to Dr. Kahn to kind of give us a little overview of the subject matter experts and their role in the PPE task force. I'm sure we hear a lot about it, and I'm not sure if people have a good understanding about it and what the role is, but I think we'll get an overview and then we'll allow for some questions. Are we okay with that format? Okay, so I'm going to silence myself and I'll turn it over to Dr. Mertz or Dr. Kahn.
Thanks, Sylvia. I'm happy to start off here and first talk about the SME, so the subject matter expert group for infection prevention and control, as well as occupational health. This is a group that actually started its work before COVID-19 arrived here, but certainly the work has picked up significantly after we had our first case and then had our first patient, etc., etc. I think in total we have more than 40 people listed as members. Members are from the entire region, so obviously HHS, we have St. Joe's, we have Joe Brand, so Burlington, we have Brantford, and we have the Niagara Healthcare System. And we have representation from infection prevention and control from all those sites. We have occupational health, we have safety with Jeff. We have many clinical experts, so Dr. Kelly being one of them, Dr. O'Leary being another one, but also from medicine, from ED, from HHS, as well as St. Joe's. And we are currently in the flux to have more clinical key stakeholders from other sites as well represented, while we are moving more into a, I would say, sustainable way for the SME to function. In the early days, we met every day for roughly 90 minutes, up to 2 hours, just to get through all the documents and policies and processes and PPE decisions we had to make back then. So we have a lot of expertise at the table. And the guiding principles for us have always been, first comes staff safety, patient safety, and having a sustainable approach in terms of limited resources that we have. Things are looking better now in terms of supplies than they had a few weeks back. But for us, one of the key pieces always was we want to keep people safe now, but also in the near future. And that's why we have introduced many of those conservation strategies that you are all now familiar with, like the extended use and reuse. So that's where this is coming from. We wanted to make sure that in 2 weeks from now, we are not running out of masks, right? Along the way, the PPE task force was developed, and Sarah can talk more to that group, which she is co-chairing, which is more looking into the operational aspect. So the SME is looking into the science behind it, make up the principles that need to be addressed or applied, and then the PP task force takes over with the implementation piece, the education, and so on. So that has resolved a lot of work that we initially have done at the SME level to have a different group co-chaired by Les Gauthier and Sarah Khan to take over the operational aspects. And I think I will flip over to Sarah to talk about the PP task force.
Yeah, thanks for that. I think Dominic's highlighted the key aspects of how there is a lot of cross communication between the SME, sort of guiding with the evidence basis, and then us, taking that rationale, principles, and the operations of it. Who sits on the PPE task force? So like Dominic mentioned, myself and Leslie Gauthier chair it, but within it we have, of course, infection control, health, safety and wellness, educators, a VP of nursing, chief nursing executive, logistics, innovation, MDRD. So we really are trying to sort of combine all the operational considerations to make sure the decisions we make are sort of equitable, harmonious, and are happening in a centralized way, so there aren't sort of variances in practice. And that really came to light when the SME was sort of doing all the work around policy, but operations sort of needed a pickup and a big group to come together to sort of make things work. Again, our guiding principles are staff safety, of course, infection control and patient safety, and then, of course, sustainability and conservation of PPE, making sure it is evidence-based practices that we're using, reconciling practices we were doing perhaps prior that may not have always had a strong evidence basis, making sure we're standardizing our approaches and optimizing sort of those key principles. So that's who makes up the task force and who's sort of making some of these operational decisions. And we do hope that we have all the right representation, and when needed, we have separate working groups that break out and deal with specific tasks. So I think that's a quick summary of what we do. I'll hand over now.
Thank you, Dr. Khan and Dr. Mertz. I think after we've just kind of heard an overview of the structure of the SME group and the PPE task force, I think I'm going to open it up at this point to see, let people to kind of digest that information and kind of reach out to see if people have questions. Kelly, maybe we can reiterate the rules of how to use the program.
Yep, if you would like to just go ahead and speak, just ensure that you unmute yourself, or you can put something into the chat box, or alternatively, if you click on the participants button on the bottom, you will see an area where you can click to raise your hand.
So maybe I'll just start with a question, Dominic and Sarah. So early on, when we first were grappling with this and we had protocols put in place, one thing that was talked about was a 15-minute after intubation, extubation, before people were in the rooms, and then that has now not been part of the protocol. So maybe could you just talk the group through the thought processes behind that and how we've now landed on where we are at the moment?
Yeah, I'm happy to take this one, Steve. So people heard that from me in the beginning. That was back in March. when we try to develop our processes, how to provide safe care to the positive patients. And those 10 to 15 minutes were coming from the TB literature. So TB being a airborne pathogen, and based on the models that we have for TB, where we would know that after 12 to 15 minutes, the air is clean somewhere between 99 to 99.9%, just based on the number of air cycles that we would have in a setting like the OR. And we applied that, or we proposed to apply this at the very beginning to COVID-19 patients as well. Then the whole discussion started that everyone, unless proven otherwise, is COVID-19 positive, which was a assumption that was probably the right one in the very beginning, when we didn't know whether we will end up with a New York City type of situation, which thankfully we did not. And in addition to that, we learned over time, and that's not just us, we are talking about the whole province, nationally, actually globally, that there had not been any transmission because people wouldn't have stayed away from rooms where a recent HEMP, like an intubation, may have occurred. Plus that generalization from TB to COVID-19 proved not to be necessary. And that's why several weeks back now, after discussions at the provincial level among the infection prevention and control experts, we came to an agreement that we don't need that sort of a downtime. So it's safe once the intubation is done, even if that patient is truly positive, and if some aerosolization happened while intubating the patient, that it's safe to come in once the process itself had been completed.
Thank you. And then just maybe a follow-up to that, Dominic, in what you said. At the start of all this, we assumed everybody was positive, but maybe you can speak to our local epidemiology about that. Really now, the vast majority of people are negative, and it's very rare to have positive people in our local Hamilton area. Is that correct?
Yeah, that's correct. I mean, the epidemiology is in flux and will continue to be so. It looked great over the last couple of weeks. Now it looks like cases may be climbing up again. But when I say climbing up, we are looking at maybe 10 patients or 10 new cases per day across Hamilton that we are aware that tested positive. We all know we are not capturing everyone, but it doesn't look like we are in the thousands of people every day, certainly not. So we are pretty much in the same situation in which we had been over the last couple of months, on average, roughly 10 new cases per day. Things haven't exploded, things went down and up very slightly. The main triggers that we had on days where we had much higher numbers of cases were the outbreaks, right? The unfortunate outbreaks in long-term care facilities, retirement homes, like the Roslin being the last one, where from one day to the next we were aware of 60, 70 new cases. But that's not reflective of what's going on out in the community. So we are for sure in a setting where we have a very low prevalence as well as incidence of COVID-19 patients. So we are in a setting where, unless proven otherwise, a patient in front of us is not COVID-19 positive. And just to add to that, and I sound like a broken record. I've been saying this since the beginning of March. The transmission we expected and then also saw over the last month across the province is much more staff to staff than patient to staff. So the PPE people are using protects us very well from COVID-19. One challenge was the staff to staff transmissions, and that's why we started with the universal masking, more to protect everyone as being a source for others. But despite all that, a lot of discussion had always been, should it be a level 1, level 2, level 3 N95 mask? It's not going to make a difference. Transmissions occurred and will continue to occur because A, we are social beings, B, we live out in the community as well. What we have to do is reducing the risk to at least the same amount that we would have if we didn't have a patient in front of us, and that's what we in general achieved with 2 exceptions, the current outbreak on the COVID-19 unit at the general and the 1 outbreak that we had at St. Peter's over the last couple of months. Back to you, Steve.
Is there any other questions that people have? Anything people want to ask? Yes?
Hi, just a follow-up with respect to the settlement time. I know the ministry had prepared a document earlier in May. Do we have any reply from our challenge? I know that many hospitals, including HHS, had challenged that because they did go back to the TB guidelines that you've already mentioned. So maybe an update on where we're at with that would be really much appreciated.
So, Dominic, I'm not sure if you heard that. I'll just repeat the question for people. Question was, when the province brought out their ramping up criteria and protocol on the 7th of May, I think it was Appendix D, involved the thing about, or had the 15-minute wait in that document. And I know we were, as an SME group, we were going to ask the province about that and whether that could be removed. Have you got any updates on whether that happened?
Yeah, we actually drafted a letter together with the vast majority of IPAC people across the province to the Ontario Health Group that developed those documents. And those documents are currently under revision, and both me and Sarah are sitting at that table. And we have an agreement that there will not be a downtime in the revised version. So it will confirm the our practice, and this will be reflected in the new guideline there.
Any questions anywhere else? Anybody?
Hi, Steve. Susan O'Leary. I'm interested in either Sarah or Dominic, if you could comment on the testing and whether or not testing is helpful from the point of view of PPE conservation and management of our patients.
Great. Dominic, did you hear that?
I heard it. Big conversation at the provincial table as well. I think we are pretty much in agreement that in a low epidemiology setting, as we currently have, there's probably no benefit in testing. So we will have to revisit that once the updated guideline document is out. It may be a different situation in a higher epidemiology situation where you have a higher pretest probability. We tested, I don't have the exact numbers because the only numbers we can easily pull is how many patients we tested pre-procedural in our assessment center. So these are the ones that didn't get the testing in the ED and had urgent surgery thereafter. But in those, I think we were at 600-700 last time I checked. And of those, we had 0 positives. We had a couple of positives in people who came in through the ED, and in both cases, OR happened before we had the test result, which really questions the benefit also locally. The main reason why we implemented the testing back then was, again, we expected much higher caseloads in terms of COVID-19 than what we ended up with. And again, we are all very thankful for that. But also, oh, now I lost my thought.
It was PPE conservation as well, Dominic, I think. That was
okay, exactly, that's what I wanted to say. But also the PPE conservation issue, because we were extremely tight with N95s for a very long period of time. Things have relaxed slightly, I would say, at this point. But again, we cannot afford everyone wearing an N95. We will be out of N95s very quickly, and then we don't have the N95s in a week or two from now to take care of patients where we truly need the N95. So it was those two aspects that played into this. And thanks, Steve, to bring me back to my thought.
And I'm correct in understanding, I think, that we now have the protocol in place at the Children's Hospital where we don't swab them pre-op and we just go on symptoms, and then we swab the symptomatic. And I believe that is very similar to a lot of the region around us where they're not doing pre-op testing, they're doing a symptom screen and then just testing who's positive.
Yeah, we are, in the meantime, we are the exception to the rule of what the hospitals in our area are currently doing. This being said, we were holding off with any changes until we have that updated document. We wanted to stay our course for now. Once we have the provincial guidance document in our hands, then to revisit our current practice.
Okay, any other questions from the group at all?
I would like to ask about the asymptomatic patients. We hear a lot about this in the media, and you were just discussing only testing patients with symptoms. Is there a percentage that we know usually may be asymptomatic? And because it does seem like it's a big issue, but I wonder if it actually is.
So I gave you the numbers we had. So out of those 600-700, we had 0 cases. That was pre-procedural. We had those couple of cases I mentioned that were ED patients, one of them being febrile. We've done asymptomatic testing in several other populations as well. We haven't picked up a single case. So it seems not to be as frequent as we might have thought it was. But again, we need to take into consideration our setting and the epidemiology that we have locally. I know from Toronto, for example, where they have a higher caseload, that in the oncology patient population, they apparently found more asymptomatic carriers than we would have. So it always needs to be taken into consideration of what's someone's pretest probability, so what's someone's risk to have COVID without us knowing. And unless our local epidemiology changes based on the data that we have locally, it seems to be an extremely rare occurrence. And I just want to remind people as well, with every test we do, we have a risk of false positives as well. And if you have a very low pretest probability, you may be as likely to pick up a false positive as you would pick up a true positive. Again, questioning the value of such testing in a situation like we are currently in.
And we do know, I believe both of the cases that were picked up sort of after the fact because of asymptomatic screening ended up developing symptoms. And so they're really pre-symptomatics, not asymptomatics. And then the screen is not just going to be symptom screen, it's going to be exposure and or risk screen. And we can give you a sneak peek again around the provincial document to come around the possibility of implementation of some home isolation period prior to elective procedures. So I think, again, there's going to be other risk mitigating strategies that can be put in. We know from our anecdotes of our 2 cases, there were no staff transmissions that occurred with the PPE policies that we do have in place. And then, as Dominic mentioned, the limits of testing being, false positives, but also prolonged shedding of potentially just RNA and not viable virus that could really infect anyone. And especially some of those cancer patients probably also shed for longer, but again, is it viable or not? And that's a challenge we have with any virus in ID that we're managing some of our febrile newts that keep shedding rhino or entro for prolonged periods. So there's more to testing than I think is just superficially seen when we just talk about it from a pre-surgical testing side.
Yeah, thanks for adding that, Sarah. And I think what we've also learned over the last couple of months was people who are positive remain negative, who were positive remain positive with their NPS for weeks, sometimes even a couple of months. And we also, in the meantime, have evidence that after 10 days, it doesn't look like you're infectious anymore. So if you do random testing and you have the occasional case who's positive, that patient may as well have had COVID-19 2, 3, 4, 5, 6 weeks ago, and simply still test positive, and the patient may not have realized that they had COVID because all they had was maybe some congestion. So that's a very important point. Thanks for mentioning it, Sarah.
Any other questions? Because I do have a question for Sarah, but I don't want to get away with. So any other questions people have?
Hi, it's Edwin. I do have a quick question. When we're speaking about false positive, conversely, the false negative, and if we're heading down the line that we're only swabbing the high risk patients, then we have to really trust the test when it is actually negative. And I'm going to get a lot of questions about what the sensitivity is and how much we can trust it. Can anyone speak with regards to the sensitivity of the assay that's being done at Hamilton Health Sciences?
Sensitivity is a challenge in the absence of gold standard, as you know, Edwin. What we can do is we can compare the first test to a second test, or the first test to a different specimen. So, for example, a sputum. People are very scared about sensitivity. So that's the piece here, whether you're able to pick it up in a patient who actually has the disease. Based on the Chinese data, which was quite low. It was reported to be as low as 70%. So you would be missing it in 30% of people. And that's very relevant. What we know, and again, that's not data in asymptomatics, because asymptomatic we wouldn't re-swab, right? But in symptomatics, looking at the bigger picture in Ontario, and that's what I've heard from the public health lab, when they compared the first swab to all swabs or other specimens obtained, they were at roughly 95%. Now, a 95% sensitivity in a low epidemiology setting gives you a very high predictive value that you can actually trust that test to be a true negative.
Good. So maybe I can ask this question of Sarah. I'm glad you're here as the co-chair of the PPE task force. So for 17 years, I've been coming into this hospital, well, first at McMaster's site, now here since ABC in 2011. And I've been putting on my duckbill surgical mask. I've been doing my procedure and having a very good time. And then I turned up one Monday, 2 weeks ago, whatever it was, and they were all gone. So maybe, Sarah, can you give us a bit of background about that and how that happened?
Yes, the beloved duckbills. We've heard so much about them.
I know, I hate change. I hate change.
Yes, change is difficult. We're all struggling these days. But just to speak to that, you're right in that, you know, there was a lot of different product on our shelves, and not all of it, I think, was vetted in the same sort of standardized way that we've now all had to start doing to understand what is there, what can we get more of, and what's, you know, safe and effective for our staff. And surprisingly, despite 17 years of use, the duckbills actually did not meet a medical grade standard that we would require for masks, in that they don't actually have any fluid resistance rating. And so it would actually be sort of a risk or a liability for us to continue to allow them to be supplied, even though the fit and the luxury of the feel, I'm not sure what it is that you guys love so much about them, it is not really going to be safe for ongoing use. So that's why, unfortunately, we had to pull them off the shelf, because it's more of a matter of, you know, ongoing staff safety and risk to you to leave them there, recognizing they do offer some aspects that perhaps our newer masks are unable to. So I think that's the bottom line, that they just do not meet appropriate standards to continue to use them. And it's unfortunate we sort of had them in circulation for as long as we did before picking up on this reality.
Right, so now, so the masks we're getting at the front door, which I'm wearing now, etc., those are level 1 masks. They do have that fluid resistance that the duckbills don't have. Obviously, they don't tie back over the head, so you are around the ears. It's a bit discomfort, and we've got the ear protectors and things to help. And I believe the PPE task force or the supplies people on that task force are actively looking for ties for us, because they're aware of the comfort part and what have we. But I think at the moment, there's not a lot of supply in the whole country, I believe, certainly province and country. Is that correct, Sarah?
Agreed. So the whole issue of the tiebacks is what we've adopted to call them now. We recognize that we do need to offer, you know, masks that are comfortable and safe for you to use. Unfortunately, there's sort of seems to be also a global shortage in getting these tiebacks. Early on in having sourced what we have, we recognized some of our ear loop quality wasn't adequate, and those got quickly taken off as soon as it was recognized these masks were moving on you, breaking on you, or potentially contaminating the sterile field, which is a huge patient safety risk. And so we are definitely vetting quality. Multiple people pilot any new box that we end up procuring to make sure that they're safe and appropriate for use in clinical care, especially a sensitive area like the OR. But unfortunately, ear loops are sort of what are available at this time. Not to say we are not, you know, looking everywhere we can to get some more tiebacks. And specifically, I can speak to the fact that we're now trying to do a trade with other centers that actually had some tiebacks and didn't like them. Like their ORs actually preferred the ear loops and the ability to use the ear protector to tighten the fit. So surprisingly, some centers are sort of the opposite of us. We've done what we can, even with trades. It seems silly that we're having to do this, but this is the reality. And aside from that, there's also some work happening from an innovation side to see if we can get tiebacks developed that are still meeting medical grade standards. So lots of work happening. We've heard the concerns. We've tried to ensure we have a temporizing measure in place. We're sourcing as much as we possibly can to get back to a tieback option, though the horizon, it does look like that's a long-term plan and not anything that's going to happen imminently, I guess, is something I need to be very frank about.
And then maybe just my final question I'll ask, and obviously people open it up for other people, is face shields and use. And I know initially the face shields we had in the OR were the put together ones, and they weren't always reliable, they fell apart. But I believe now we have a different type of face shield in the ORs now, Sarah.
That's correct. So face shields are definitely our friends. We've had lots of meetings to make sure that we are supplying safe, quality product that will work for the different areas. We've now been able to source sort of 2 main suppliers that will be able to give us a good long-term supply of a quality product. And you're right, the early iteration of one of those fell apart on us, and that was not okay. But so, you know, they've retabled, they've gone back to the drawing board, they've revised the strap itself, and we've gotten good feedback. Before we put anything out into circulation, we pilot it in different areas, and in fact we're now sort of able to offer one of the 2 products for piloting to most areas to see what people prefer, and we're implementing a standardized way to reprocess them through MDRDs at the general and JERV respectively, and getting back the same shield you like back to you in your unit in a safe way that is an entirely reprocessed and clean piece of equipment coming back to you. And again, your preferences are accounted for. So we do hope that the face shield, you know, issues we were having before have essentially been resolved. And the reprocessing piece, again, it's still being sorted out a little bit, but we've piloted, I believe, at the JERV, and I think we're starting piloting at the general once the new equipment that was acquired for reprocessing of face shields has been fully safely vetted and is working well for us. So that's the update on face shields. There shouldn't be inadequate product now, and we're still hearing and taking feedback. And really, if there's a PPE issue, we are very open to emails. Les and I get a lot of emails, a lot from the Periop group, but other areas as well. We do take feedback. It's meaningful for us, and we try and work with it to make sure you guys are feeling safe and comfortable with the product you have.
Excellent. Any other questions from all the groups? I'm just mindful of time. We've got 15 minutes left. So I think Kathy Craig is going to come and chat to us now. And I would just like to echo that last point that Sarah made. Very responsive, both the SME group and Dominic and the PPE group and Sarah. Lots of emails from me over lots of subjects, very patient. And they do look, and they will go looking for things and try to source things for us, the PPE group especially. So I'd just like to thank them for all their hard work over this extraordinary time. And I'm going to turn things over to Kathy now, if that's all right.
Hello, thank you very much, Dr. Kelly. So I'm going to talk about the Ministry of Labor visit that we had. Can everybody hear me okay? Am I talking loud enough? That we had on Monday. And a lot of you may have never been on a Ministry of Labor visit before, so I'll just give you, I know Sylvia has, Dr. Mertz has, Jeff of course has. I'm not sure if anybody else has been involved in a visit before. So what generally happens, there's a couple of types of visits that the Ministry of Labor will do. They will do a proactive visit, which they did here at the Juravinski Hospital on March the 11th, a proactive visit for COVID-19 to check our preparedness, or they will come in for a complaint, or if we report an occupational illness or a critical injury. So this visit on Monday, they came in for a complaint. They received a phone call from a worker and in the OR. So we get a grouping of people together for the complaint. We always have a worker member from the Joint Health and Safety Committee. That's a must that we must have. We try to find out which union the complaint is coming from so that we can make sure that our union representative is from that union so they understand the work that you do. So we had Judy Mulligan, who's your owner rep on the Joint Health and Safety Committee, was at that meeting, as well as Sylvia and myself. And we did have another worker member there who was new to the committee. It was her very first day in the Joint Health and Safety Committee, and it was a good learning opportunity. So she came as well. So what happens when the Ministry of Labor comes? They may come and take a look at the area because of the, they don't even want to come into our hospitals right now. So because of that, she did not come down to the OR. And if she was going to come down, she would have had to get scrubbed up and to go in degrees to go in. So what we did, she had asked for pictures of our PPE. So Sylvia had taken some pictures of the PPE room. I made a little slideshow for her so that she had pictures of what the PPE room looked like. So she goes through the complaint. There were 3 things on the complaint. The first one was to do with the level of mask being used, the second to do with the reuse, and the third to do with the hand sanitizer. She goes through, she asks us questions about what we have in place. She compares that against to what we should have in place to determine if we're meeting the guidelines. And in this case, it's the CMOH directives that we need to meet. So she went through, saw that she was very happy with what was being done in the operating room. She was happy with the PPE room. That was an excellent thing that was done for you in the OR to have that PPE room set up the way it was. So she had no issues with what was going on with the level of masks, that you are getting the protection that you need for the job that you're doing. You do have the opportunity to do a point of care risk assessment. If you determine you need a higher level of PPE than is given to you for the onset of the surgery, then you are able to get that. It's readily accessible to you to get that level of PPE. Everybody's fit tested in the OR. As a matter of fact, many of you are fit tested for more than 1 mask. We're doing a conversion, and anybody that's on the 1860 or 1860S, we have a lower amount of those. So we've been moving you over to 1870s or 8110s. And you're in very good shape for your fit testing. So she was happy with that. Any questions about that part of her? Nope, nothing on that. Okay, then the second was on the reuse. So we went through how we reuse a mask, talked about using the container, that we have a video on how to use the container, that Denise has done a lot of training with the staff on some training on using the container, how to use the container, how to take your mask off so you're not touching the outside of your mask. And then, of course, if it becomes soiled or damaged, you're going to discard that mask and get yourself a new mask. So there was, everything with that was okay. Does anybody have, and then with the face shields and goggles can be used, they're washed with soap and water and reused as needed. And then, of course, if it gets so you can't see through your face shield, you're going to discard that and get a new face shield. Did anybody have any questions about that part? And then the last part was about the hand sanitizer. So this just came to light maybe a week ago, that some of our hand sanitizer was made with a technical grade ethanol. So we have 2. There's a microsan sanitizer, which is not in the ORs, it's in the ICU. they're on a trial. You'll see some at the front doors. Somebody from the ICU had received a notice that with an insert from another hospital, not from our hospital. If you received a box, if we received a box of microsan that was made with the technical grade alcohol, we would have received the insert in the box and we would have been made aware of that. We did not have any of that on site at the Juravinski. There were 2 boxes down at the general, but they were still in the box and they were removed. The other one was the Triton that was refilled. The bladders were refilled for the Purell dispensers and they were put in the Purell dispensers. Originally, when we received the Triton, we did not have those warnings. We were not made aware that it was a technical grade alcohol. Once we became aware of that, the problem with, sorry, I should have mentioned what the problem with the technical grade alcohol is you shouldn't use it if you're pregnant, if you're breastfeeding, or if you're trying to conceive. So as soon as we became aware that the Triton was made with the technical grade ethanol, it started to get pulled from the shelves. You may still see a Triton label, should have an X to it, and then there should be a Happy Hands label if it's now been refilled. If the Purell dispenser's been refilled, it should be with a Happy Hands, which is made with food grade alcohol, which does not have the warnings for pregnancy, breastfeeding, or trying to conceive. So that has been, all of that has been removed from our site now. Any questions on that?
Is it the type of alcohol that's used, or is it the amount?
No, it's the grade of alcohol. So it's ethanol. It's 70% ethanol for all of the hand sanitizers, but there's USP grade, which is what generally ours is with. There's food grade, which is also fine for the hospital, but then there's the technical grade, which has some impurities in it that you wouldn't have in the food grade or the USP grade.
Sorry, Kathy, it's Michelle. We didn't hear the question.
Oh, sorry. The question was it different kinds of alcohol? Different kinds of alcohol? Was that what you asked?
I just wanted to know whether it was like a level of alcohol.
Oh.
Or like a type
I
of alcohol.
wanted to know if it was a level of alcohol or a type of alcohol.
I see that we have a question from the PACU. So many of the staff are noticing that they're having difficulty securing the mask when they have glasses on, and they're unable to prevent fogging. Are there suggestions or different types of masks that would help with this situation?
I'm mindful of the 8 minutes remaining. I don't know if we jumped over the alcohol question, but it's a technical grade alcohol that there is some discussions or more investigating happening. It's the same 70% plus alcohol that we require for medical grade ABHR. So I hope that closes the loop on that. And I didn't mean to interrupt Kathy if you're still talking about the MOL visit. I did reply to Sylvia about the fog issue that I can happily speak to that quickly now too. I just forgot to chat to everyone, but essentially there are 2 products for face shields that I mentioned earlier. One is called the PT packaging manufacturer, the other is Whitebird. Regardless, on the newer models of these, we've heard less complaints about fogging, whereas a previous one, it had more of a, we call it the Darth Vader look. It's sort of more of a hockey helmet kind of look that that did have a bit more fog challenges. So I'm not sure if that might address the concern if you get to try out the new 2, if that will help deal with fogging. The other thing that, some people have used, and I think Steve uses this as well, is sometimes put a little piece of tape at the nasal bridge under your glasses, and also just reduces how much humidity comes up from your breathing up to fog your glasses. So those are sort of some risk mitigating strategies. If there's still a fog concern after you try the new products, we can see if there's other adjustments that can be made, but that's a starting point.
Yeah, certainly, Sarah. I was putting tape on my beloved duck-billed masks anyway, so I've been doing that for 17 years. So just a little bit of microporial soft tape just on the bridge of the nose, which tends to stop the fogging up. Kathy, was there anything else you wanted to add from your?
No, I had nothing else to add, just if there were any questions on the information.
Did the Ministry of Labor specifically address concerns with regards to plume, smoke plume?
That was not brought up in the complaint that was given to the Ministry of Labor. So they will talk to the complaint that's brought forward to them.
So certainly, so certainly the smoke plume, I can speak to that, or certainly Dominic or Sarah, certainly you should be using smoke evacuating devices for this the whole time. You should be using both for an open cautery and also for laparoscopic. You should be using those the whole time. One of the things you need to remember, and certainly at the beginning of this in the surgical societies throughout the world, they all brought out these recommendations for various types of surgery in COVID positive patients. One thing is you tend to forget is certainly I do, is a mistake I make, is I seem to think that the high standards we have at HHS are the standards they have everywhere else. A lot of the American standards coming out about saying you must use a smoke evacuator is because a lot of American hospitals don't use smoke evacuators routinely. So I think that our levels of protection for our staff are a higher level. So certainly, and we've talked a lot with in the OR protocols and things for the surgeons about, should you be doing laparoscopic work, which initially people were saying you shouldn't be doing. Now everybody's saying actually you should be doing it, it's fine. But you've got to think about how you do it. You've got to have smoke evacuation. You've got to have the lowest pressure you can have. When you're removing the pneumoperineum at the end of the case, you don't just open up the ports, you just allow the smoke evacuator to remove it, etc. So there are lots of ways to mitigate the smoke plumes, as you say. Dominic or Sarah, did you have anything to add to that?
No, I think you hit the nail on the head there. In terms of, if you look at all the CDC, FDA sort of recommendations about plume, it's about all the smoke evacuation, the air exchanges. That's your main line of defense. PPE is your last line of defense. And really all those other processes need to be in place and are in place at HHS, and we can speak to that. I think Jeff might be able to speak more to the toxicity concern around plume, but you may have seen previous laser masks. That's more of a marketing kind of scam. They just add laser to the box, but it's not any really different than what sort of our ASTM rated masks are otherwise available. So we did have a plume recommendation with a couple bullet points in the last memo that went out, but I'll let Jeff talk about the particle filtration and the relevance or not to plume at this point, because that's an OC health issue.
Yeah, I can pick up on that. So just like the duckbill masks didn't meet all of our standards in terms of fluid resistance and particle efficiency, when we looked at the laser masks, it was very much the same thing. They tended to meet one of our criteria, which was particle efficiency, but they didn't meet fluid resistance, and they didn't always meet bacterial filter resistance. So the decision was made to remove them in lieu of a level 1 mask, which actually provides the same level of particle removal efficiency, down to the same size particle as the laser masks do. So you really have the same level of protection in terms of the mask. But as Sarah said, the real control that we want to have in place and to be used diligently are the plume evacuators, and of course the general ventilation in the room.
Can I add something to that? Because in addition to air exchanges and smoke evacuation with the cautery, we also have additional filtered smoke evacuators called buffalo filters. I think organizationally we do a really great job of maintaining as best as we can the air quality. And the laser masks really didn't have any metal, so that was one of the components that were important for a laser type mask. So I think that's how people would look at them sometimes with respect to using the laser. So just to add that.
So I have 4:58 on the timing. Sylvia, did you want to add anything?
I don't have anything. I'm sitting down here, so that's okay. Sorry, we're kind of like passing the same computer around here. I personally don't have anything further to ask or to say, other than as a manager, and I got my colleague Kelly on the phone, we both co-manage the areas together. I do want to say that these are challenging times, but you guys have done fantastic work and continue to do great work, and we continue to provide the best care to our patients on a daily basis, and thank you for that. I sat back today and I reflected a little bit, and I remember that day when that first COVID patient came in through the Emerge. We had one nurse crying, another one was throwing up in the garbage can, and we're like, oh my God, this is here. And Denise and I were here supporting the team till late at night. And we have come a long way, and we have supported each other, and we continue to support each other through this change. And like Sarah said, change is difficult. It's difficult in our work life. It's difficult in our personal lives. And we're just creatures of like a nature that we just want to be left alone and want to do the same thing day in, day out. But sometimes these opportunities come on our doorsteps like COVID, and gives us a time to pause and relook at how we do things, and kind of relook at how we do it, and have the opportunity to do things differently. So on behalf of all of leadership, those that are on the phone and those that are not able to join us today, a big thank you to everybody. I hope that we have been able to maybe answer some questions that people had. And I will extend, just like Dominic and Sarah did, they are open to questions. If we ever have any further questions that we feel we need to ask, please don't hesitate to ask me, email it to me. I will, I'm not an expert, but I have the support of my team that I can ask the questions to. So don't ever feel that you have a question that you can't be answered. Like, we're here to help you. I might not have the answers, but I definitely will reach out and try and get you the answers. So on behalf of all of us, I thank you very much, and thank you to everybody for taking an hour out of your day. Some of you have worked all day and are on your own time now. Thank you. And Michelle, I don't know if you have any closing words.
Thanks, Sylvia. Yeah, I echo all your sentiments. We appreciate the work that everybody does every day. We know these are challenging times, and it's really important to us as leaders that we try to keep the team safe. So, yeah, I agree with everything that Sylvia has just said. I just want to say a thank you to our panel today, Jeff, Dominic, Sarah, and Kathy. Thank you for taking the time to help us talk through this with the team. We really appreciate it.
Okay, well, I wish everybody a lovely evening. I think the sun's still shining. I hope everybody goes out and enjoys it, because I think we're calling for some rain tomorrow. So thank you, everybody, and have a nice evening.
Thank you, Sylvia.
Thanks. Bye-bye.